My name is Jenna Khan. I'm the other course director for this virtual radiation oncology elective. By now, you would have watched the 3 videos from YouTube, from the ROCSIG website, which are on introduction to radiation oncology, radiation biology, and physics, and more in depth about radiation oncology. I'm going to give a reiterative talk on introduction to simulation and contouring. I'm an assistant professor at OHSU. And I wanted to start off by explaining that radiation oncology is a team sport. From the time that we see a patient, they have contact with the front desk, nursing, us as physicians, CT, SIM, radiation therapists, dosimetrists, physicists, and therapists. As a care path, when a patient comes in, they first get a consultation, then they undergo simulation. We do contouring, planning, quality assurance. Then we set the patient up for their treatment and deliver the radiation. Subsequently, we see them on weekly on-treatment visits and follow up with scans and managing symptoms. So what is simulation? We place the patient in the treatment position to obtain imaging for treatment planning. We mark the patient for the intended treatment field of treatment, and we document all of those things. It's tailored for each patient, and the goal is to maximize target and avoidance structure ratio. So we're trying to maximize making sure that we maximize our target and avoid other structures. We want to visualize the target well, but we also want the patient to be comfortable because that leads to patient safety and reproducibility. Simulation room often is a room with a CT scan or an MRI. In the old days, they used fluoroscopy, and sometimes you can use ultrasound, but it is the initial step in your treatment planning. The table that is used is similar to the treatment vault, and we are imaging the patient in the actual treatment position. Here you can see a CT scanner with the table that we would use for their treatment. We use immobilization devices to minimize motion during and between treatments. We don't want as much movement. When we talk about movement during the radiation, that is called intrafraction movement or intrafraction motion. When we talk about changes in patient position from day to day, that's called interfraction motion. Here you can see some masks that are made for some of our pediatric patients, and that's to help put them not to be moving during treatment, as that movement during treatment would be intrafraction movement. So what are some other devices that we use? This blue bag is kind of like a bean bag, and it is shaped to a patient. It's called a backlock bag, and it's shaped specifically for each patient. This is an abdominal compression to make sure their breathing, their abdominal breathing is not as large, and to keep them into more of the treatment position. This is to make sure and to help the patient remember not to be moving their feet as much. And you can see this mesh-like material that is called aquaplast, and that's to help make a mold of a patient so that they stay in that treatment position. Other treatment positions are breast immobilization. This is a breastboard with areas for them to put their arms and to be comfortable during the treatment. This is a treatment machine and a patient lined up. You can see here the laser so that she's perfectly lined up during the treatment. Other ways that we can immobilize breasts is to place them into a prone position. That's where they are on their abdomen and the breast falls through into this hole with their arms above, and that can lead to optimization of decreasing other target structures during your treatment. For brain tumors and head and neck immobilization, we can use these aquaplast masks again so that patients are not moving during their treatment. This is especially important when we are treating to the head and neck area and brain. When we talk about abdomen, we can think about putting a patient on their back or on their belly, and this can help with moving other targets out of the way. So for instance, this patient is in the supine position, and you can see that when they're pushed into the prone position on their stomach, a lot of that bowel moves out of the way, allowing us to decrease treatment to areas where we wouldn't want our radiation to go towards. This is also shown when we ask a patient to have a full or empty bladder. You can see here in yellow is a bladder with a full bladder, and it pushes away some of the small bowel away from getting treatment. When a patient has an empty bladder, some of their bowel pushes right into where the bladder was, potentially pushing into the field of where the radiation would be. Other simulation aids include an anal BB, meaning a marker that shows us where the anus is. As you can see here, it's kind of hard to tell, maybe that's the anus, but a marker helps us to very well delineate that. Rectal contrast, we can put contrast into the rectum to make sure we know exactly where the rectum is. IV contrast helps us to delineate vessels, especially when there's a lot going on in a pelvis or other parts of the body. And oral contrast can help us with delineating certain parts of the bowel or stomach. Other things that we can do to track or help us with our treatment delivery is we can use different kind of imaging to track the tumor motion during the treatment. So that might be in prostate cancer, we can put fiducial markers or gold marker seeds or calypso marker seeds. Those are markers that are placed into the prostate so that we can watch them move during treatment or line up to these marker seeds. There's also CyberKnife, which follows along with internal fiducial markers as internal target motion occurs. Align RT is an infrared surface imaging and allows us to track the tumor or the patient as well. Active breathing control, or ABC, is kind of, I always say, is kind of like snorkeling, where we can continuously monitor the lung volume And we only turn the treatment machine on when it's the ideal time. The advantage to it is that we have reproducible breath holds. It allows us to treat a smaller tumor volume or margin. And the disadvantage is it's a little more time intensive. It's a little harder for some patients to do, but it can also cause longer treatment time. So in this, you can see we plug the nose and only allow them to breathe through this tube. When they're breathing, we can watch them breathe, and then they would hold their breath, and we treat during this green time and where they're holding their breath. Some of that advantage you can see here. This is for a breast patient. If you place the treatment beams on to this patient when they're just breathing normally, you can see that the heart is within the treatment field, and so this heart would get some of the dose of radiation. But when they are taking that deep breath and it pushes, the lung pushes out in front of the heart and allows us to not treat as much of the other normal structures such as the heart. At simulation, we place what's called an isocenter, and that's a point in three-dimensional space, which is the central ray of the radiation beam. It's usually in the middle of the tumor. So here you can see all of these laser lights that are convening in on this tumor. Once we have set up the patient, we have placed our isocenter, we mark the patient. They get permanent tattoos. Those tattoos are very small, if you can see here. It is, I always say, like the size of a freckle, if not smaller. But those are permanent, and they help us to line up every day. Once we are done with the simulation, the CAT scan or imaging, such as an MRI, gets pushed over into the treatment planning software, and that is when the contouring takes place. Contouring is the delineation of target volumes as well as organs at risk. There are great contouring guidelines and atlases. This is a pelvis, and each structure is drawn out, including here's a rectum, here is the pelvis, here are the lymph nodes, and we're drawing the target as well as normal structures. And this is kind of how we do that with a computer system, which you'll be doing during this course. Again, here we're drawing out where the bladder is, where the rectum is, and where the prostate is and the seminal vesicle. So places that we want to treat, and then places, we want to avoid and not treat as much. So the idea of the contouring principles is we have a GTV or a gross tumor volume, a CTV or a clinical treatment tumor target volume, and a PTV, a planning target volume. So let's talk a little bit more about what those are. The gross target volume is your tumor that you see on imaging. So if this is your tumor, this in blue is your GTV. That's what you can see on imaging. But because we can't see everything on imaging, we have a clinical target volume, which is a CTV. It's the margin around a GTV to account for all of this subclinical or microscopic disease that spreads and we can't see on imaging. The CTV, or clinical target volume, can be uniform or non-uniform as to respect anatomical boundaries, such as a lung cancer that's likely not going to leave the lung, or a brain cancer that's likely not to leave the brain. So we base that based on anatomic boundaries. Lastly, we put in a planning target volume, which is a PTV, and that's a margin around the CTV to account for uncertainties in planning or treatment delivery. It brings back that intrafraction and interfraction thoughts, and we think of how patient setup error every day. So most institutions and most machines are anywhere from 3 to 5 millimeter precision. So we add a 3 to 5 millimeter PTV. That PTV, planning target volume, is not changed at all once it's expanded from your CTV. There is an internal target volume, or an ITV, which is your CTV plus an internal margin of the target. That allows for compensation of internal motion, such as respiration, swallowing, bladder, and or rectal filling. So an example would be a lung cancer. The lungs, while you're breathing, are moving up and down, side to side. And we want to account for that internal target motion by watching with a 4D CAT scan every phase of breathing and accounting for that with an internal target volume to account for the entire tumor motion. Organs at risk are called OARs. That's any normal organ or tissue in close proximity to the target or in the path of the radiation beam. And so we contour those separately and make sure that we have specific dose constraints to those. After we have done our contouring, we will move to treatment planning, where a medical dosimetrist and physicists work together with a physician to develop an optimal treatment plan. And you'll get another lecture on that tomorrow with more details on treatment planning. But for example, here is where a field that wants to be treated, and here is one of the beams of radiation from the front, from the back, from the right side, and from the left side. These are the beams that the linear accelerator put out and make a plan. You can see that plan with all of these beautiful colors that show our dose distribution to the target that we are trying to give the radiation to. We then evaluate the plan. We look at the dose volume histogram, which is shown here, which is looking at our target coverage, how well we covered our target, and also looking at the OARs, or the organs at risk, and looking to see what dose that those organs at risk can or did or will receive with the radiation. There are certain dose constraints, meaning doses that can go to certain organs at risk that we worry about, and that's how we evaluate these plans. After we've approved the plan, a physicist performs a check, and often via simulation of the plan on the actual treatment machine. It ensures accurate delivery of the intended radiation dose and extent prior to the patient's first treatment. These checks are often performed after work or after hours to minimize disruption to patient treatments. So here you can see a quality assurance type machine that the linear accelerator is going to give our planned radiation dose, and it's going to check to see if what I or a physician has said to treat is actually being delivered by the treatment plan. So it's a quality assurance or a double check on our machine. On the first day of treatment, we do a setup for verification, and that's where the target plan from this X-ray or this digital reconstruction is compared to the imaging that is done on the first day of treatment. And we line that up to make sure that the pelvic bones, for instance, on this case, are exactly lined up to what we wanted to prescribe to. Once that is approved, then the patient is treated. And here you can see a radiation therapist with a patient on the machine, and the machine will give the radiation. And so while they're getting radiation, not only can the radiation therapist see the machine, what it is outputting, but it also, they are watching the patient to make sure that they are comfortable and not moving during the treatment. Here you can see a patient and a treatment machine, and here is where the radiation is coming out from behind. We'll be talking more about dosimetry and contouring tomorrow, but hopefully that gives you a good overview of what simulation and contouring entail. Thank you, and please let us know if you have any questions about this.